Here's Jennifer, Carol, and two surgeons, Dr. T.C. Lu and myself. Let me welcome the first presenter, Dr. Wang. Dr. Wang, please.
Hi, good afternoon. The topic I'm going to talk about is orthodontic considerations for surgical orthodontics in cleft patient. Residual cleft deformity in skeletal aspect include midface retrusion, prognostic mandible, and facial asymmetry. Residual cleft and in soft tissue, deformities include inadequate upper incisor show, thin and less flexible upper lip, hypertrophy lower lip, imbalanced lip posture, abnormal nasal anomaly, and oral nasal fistula. The reported incidence in dental aspect, residual cleft deformities include midline discrepancy, anterior with or without posterior crossbite, open bite tendency, occlusal plancant, skewed arch form, and dental agenesis, dental crowding, and residual alveolar defect. Orthodontic surgery is performed when the patient has complete facial skeletal growth to correct residual dental facial deformity and asymmetry. The reported incidence of the need for orthodontic surgery in cleft patients varied widely, but is generally quoted as approximately 25% of the unilateral cleft patients. The general treatment principles for cleft OGS are very similar to those used when performing surgeries in non-cleft patients. Two-jaw surgeries with maxillary advancement and mandibular setback is usually adopted for better result and stability. However, pre-surgical orthodontic preparation for cleft patients is often needed due to severe dental deformities. Firstly, we observe the outcome of previous ABG and the periodontal condition of cleft adjacencies and the existence of oral nasal fistula. Successful alveolar repair in a mixed dentition with either alveolar bone graft or gingival periosteoplasty allows greater orthodontic control of alveolar segments, improves dental positioning within the maxillary arch, facilitates eruption of the cleft dentition, and closes alveolar and oral nasal fistula. This approach will make all future orthodontic surgical approaches simpler procedure. Patients with failure from previous alveolar repair or missing the previous ABG treatment show large residual alveolar cleft with ONF and dental gap, which result in difficulties in primary closure and poor result of tertiary bone grafting might be expected. Segmentation of the maxilla is needed to narrow the alveolar cleft together with OGS as an effective one-stage approach to manage the jaw discrepancy, residual cleft defect, and the oral nasal fistula in patients who has not had the benefit from mixed dentition bone grafting. The surgical closure of residual cleft dental gaps through differential maxillary segmental repositioning was performed to approximate the maxillary segments. Dead space of the cleft alveolus was closed, and the labial and palatal flaps were approximated to allow for straightforward closure of the ONF without tension, while providing keratinized mucosa to surround the cleft side and adjacent teeth. If without approximation of the large alveolar cleft, there was dehiscence and gingival recession because of tissue tension on closure of ONF. The gingival recession will be even more severe if the tooth root of the cleft adjacent teeth on the lesser segments has been exposed out of the alveolar bone. Segmentation of the maxilla through the prior cleft site can surgically close dental gaps, ONF, residual alveolar bony defect, or to achieve adequate transverse arch coordination together with OGS. To increase the success rate, it is imperative to upright cleft adjacent teeth presurgically by orthodontic approach. This allows the surgeon to maximally approximate the edge of the two alveolar segments and minimize the tension in closure of soft tissue. Since the residual alveolar cleft often showed a pyramidal shape, wider in the nasal part and narrowed in the oral part, elimination dental interference is key to approximate the alveolar cleft by segmental osteotomies. The great majority of cleft adjacent central incisor and canine are severely tipped into the cleft, which might impact the segment approximation. To increase the success rate, it is imperative to upright cleft adjacent teeth presurgically by orthodontic approach, either by dental extraction, arch expansion, or orthodontic screw for distalization of cleft adjacent teeth. Most of the lateral incisor in the cleft site is unusable in the final occlusion and is extracted during the surgery. Uprighting the cleft adjacent teeth must be performed with caution, realizing the funnel shape of a pyramidal of a typical cleft defect. When patients are prepared orthodontically for segmental osteotomy, the teeth approximating the cleft should be upright with good supporting bone on all aspects of the root surface. This case had presurgical orthodontic treatment to upright cleft adjacent teeth. Dental interference was eliminated for proper approximation of maxillary segments. Upper right lateral incisor in the cleft site was extracted at the time of OGS with segmentation of maxilla to close the alveolar gap. Quite nice alveolar bone condition of cleft adjacent teeth in this case was achieved. Dental gap and ONF was closed with acceptable dental occlusion. Sometimes we eliminate dental interference by extraction of cleft adjacent teeth at the time of maxillary segmentation. In this case, left side cleft case, upper left lateral incisor is congenital missing, and upper left central incisor showed infraocclusion with large decay. The way we eliminate the dental interference for better approximation of maxillary segment was to extract upper left central incisor at the time of OGS to allow for bony approximation without presurgical orthodontic treatment. Another case, in this right side cleft case, residual alveolar cleft defect and ONF existed. Severe tilting of upper right lateral incisor and residual root of upper right canine were shown. The way we eliminate the dental interference for better approximation of segments was to extract upper right lateral incisor and residual root of upper right canine at the time of OGS to allow for bony approximation. 3D simulation can help the evaluation of the residual alveolar defect after segmental approximation. Dental gap and ONF was closed with acceptable post-op dental occlusion. Maxillary segmentation also helps to solve the problem of other dental anomalies and agenesis. In this left side cleft case, upper left central incisor showed severe external root resorption due to caries with hopeless prognosis. We planned segmentation of the maxilla to close upper left central incisor extraction space at the time of OGS, setting the upper dental midline between upper right lateral and upper central incisor for the sake of occlusion. 3D simulation can also provide some reference numbers for bone reduction during the segmental approximation. In unilateral cleft cases, upper left lateral incisor in the cleft side is often missing, causing asymmetric arch form with midline shift, which result in difficulties in surgical occlusal setup. Without pre-surgical correction of this, a lot of rotational maxillary advancement may cause posterior crossbites or arch incoordination, which will complicate the post-op orthodontic treatment and make it very difficult. To prevent this, an asymmetric extraction may be required as part of the combined orthodontic orthognosic treatment plan to pull back the midline and make arch form symmetric before surgery. In this left side cleft case, upper left lateral incisor is missing with midline shift to the left and dental crowding in the upper right quadrant. Upper right second premolar was extracted to relieve crowding and correct midline and arch form before OGS. Acceptable dental arch coordination and post-op occlusion were achieved. Facial profile and upper dental midline were also improved. This is a case with severe dental crowding due to arch space deficiency. We extract 2 teeth in the upper and 2 teeth in the lower to relieve the severe dental crowding before surgery. By doing so, we hope to avoid the interference for proper surgical occlusal setup. The next one is about the expansion of collapsed dental arch. Cleft patients experienced a decrease in the width and length of maxillary arch in early adulthood. Therefore, the collapsed upper dental arch and uncoordinated transverse dimension is the common issue we have to deal with in cleft patients. Any types of expander is rarely needed to restore the collapsed upper dental arch. Regular fixed orthodontic appliance in combination of sequential wires could gradually restore the collapsed upper arch. As a proper sagittal relationship between upper and lower jaw is then established, sometimes neither segmental osteotomy nor expander is required to coordinate the transverse dimension. In this case, we relieve the dental crowding, which arch expansion in the upper and in the lower as well before surgery. However, severe proclination of lower anterior teeth with large overjaw after coming out after decrowding of the lower dentition. The left side picture shows the result of large maxillary mandibular discrepancy with large A and B, too much setback of mandible after surgical occlusion setup with level 1 and BSSO setback. So in the end, we performed level 1 and BSSO with co-procedure through the extraction of bilateral lower first premolars extraction site as our final surgical design to achieve a better, proper numbers of the mandible movement. Let's go back to see her initial lower dental arch. The dental arch The dental crowding showed not only in the anterior but also in the posterior teeth, second molar area. Initial anterior negative overjet is already to some extent. Considering this fact, actually, lower two premolars should have been extracted for decrowding instead of just leveling and alignment with expansion. This can simplify. By doing so, this can simplify the mandible's surgery to BSSO only without co-procedure. However, the post-op self still showed quite acceptable result. Facial profile was improved a lot with acceptable post-op occlusion. Tujo surgery is planned mostly for aesthetic reason and stability. Overcorrection may be planned in inferior repositioning or surgical rotation. The relapse of horizontal direction is about 24%, and the vertical direction is 54%. Special attention should be paid to a patient with bilateral cleft, multiple missing teeth, or shallow post-op overbite. In cases with bilateral clefts, we perform to plan tertiary bone graft in smaller cleft site to stabilize the mobile premaxilla at least 6 months before the final phase of OGS. Next, I want to share a case of my cleft OGS case with more horizontal relapse of maxilla. After OGS, the final result still showed negative overjet in this case with more retrusive maxilla comparing to the mandible. From the superimposition, we can see the final amount of maxillary advancement is only 5 to 6 millimeter comparing to 8.5 millimeter of our original design. Dr. Hochman reported that larger amount of advancement is a contributing factor to the larger relapse tendency in cleft patient, which means more overcorrection is needed in cases with larger amount of maxillary advancement in cleft case. So larger anterior overjet is strongly suggested for surgical occlusion setup in cleft OGS cases like the previous case. Next, I want to share a case of my cleft OGS case with vertical relapse. This is a case with severe anterior open bite. We designed level 1 advancement with raw correction and BSSO counterclockwise rotation for her. However, immediately after surgery, the anterior open bite relapsed a lot. Anterior open bite is still there. The mandible has some relapse of direction of counterclockwise rotation. The post-op combing CT showed there is a premature occlusal contact in the left terminal molar, which might be the reason of open bite relapse with the posterior part of distal segment went up. So the lower in these figures, the lower one surgical occlusal setup is much strongly suggested than the upper one to prevent open bite relapse due to premature contact in the posterior teeth. In cases with severe anterior open bite, we strongly suggest to have surgical setup with larger posterior open bite. And larger anterior, when we are considering the surgical occlusal setup in cleft OGS, large anterior overjet and overbite is strongly suggested for surgical occlusion in cleft OGS case. To achieve that, we can do some pre-surgical orthodontic treatment to avoid severe occlusal interference, embedding a stable surgical occlusion, which often seen in the cleft case. We can also do some position adjustment of the upper first premolar position to avoid interference to achieve larger overbite setup in cases with canine substitution for lateral incisor. Posterior open bite to some extent is strongly suggested considering the relapse tendency. These left side cleft cases showed skewed and collapsed arch form with dental crowding, missing upper left lateral incisor, and partly lock-in upper left second premolar. In the pre-op X-ray, we can see that the maxillary occlusal plane canting with left side up and with compensated supra-eruption of lower left posterior teeth, causing increase in height of dental alveolus in the left side. This kind of alveolus asymmetry and canting is quite often seen in the cleft patients with less maxillary growth in the cleft side comparing to the normal side. After 3D simulation with two-jaw surgery, the left side mandibular border is in much lower position than non-cleft side. 3D surgical simulation can provide some measurements for references for the left side mandibular border contouring for better symmetry. Finishing X-ray showed corrected occlusal plane cant and improved symmetry after surgery. After treatment, occlusal plane cant is corrected and mandibular border is also consistent with it. The photos showed acceptable final occlusion with lateral incisor substitution for central incisor. A more pleasing profile and symmetry are achieved. In conclusion, successful alveolar repair in the mixed dentition stage makes future OGS simpler. Eliminating dental interference is the key to approximating the alveolar gap with maxillary segmentation to solve residual ONF and alveolar cleft. Presurgical orthodontic treatment with arch expansion and midline correction is often needed to eliminate dental interference in the surgical occlusion setup for cleft patients. More overcorrection in surgical occlusal setup for cleft patients is needed than non-cleft patients, both in vertical and horizontal aspect. Thanks for your attention.
Let me continue the presentation, and I'm going to talk about how to use a composite occlusal spring for the patient with cracked lip and palate, because patient with cracked lip and palate often they need orthodontic surgery, and we usually do two-jaw surgery because two-jaw surgery can really solve the problem not only for occlusal relationship but also for patient facial profile, proportion, and also correct the asymmetry. So over the years, we have already changed a lot of treatment policy, and we are now using 3D simulation because conventional planning with 2D image really could not solve much of the problem, especially for yaw rotation. So if you consider patient with a yaw problem, two-dimensional image really is not very helpful. So I think 3D simulation is the key to solve many problems. And of course, you need to have this facility. And I believe that the software will become more and more popular and more friendly, and also with lower price. And also for patients with credit and palate, I think that the 2-jaw surgery is really required instead of 1-jaw surgery, because the patient not only have AP discrepancy, but also they have facial symmetry. The cleft size always is more hypoplastic. So you need to lengthen the cleft side, you need to shorten the non-cleft side. So 2-jaw surgery is really required. Whether you use double jaw, double spleen, or single spleen, I think it's up to you. In our center, we have surgeon using 2 spleen. We have surgeon using single spleen. The advantage of using single spleen is that you can do more assessment during the operation before you fix the maxillomandibular complex. We call it MMC. So if I use single spleen and I need to mobilize, to shift, to rotate the maxillomandibular complex, then I believe that with this composite occlusal spleen really can provide more information to evaluate the midline, the raw rotation, the yaw rotation, etc. CAD-CAM has been utilized in our design. I think, again, this CAD-CAM, if you start to get familiar with this program, it is not difficult. 3D printing, of course, if we want to do this, we need 3D printing. But I believe that outsourcing company, they can also provide similar practice for you. So in the 2-jaw surgery, using a single occlusal spleen, during the operation, we fracture the mandible, we osteotomize the maxilla, put it together, and then we need to rotate. We need to mobilize the maxillomandibular complex. So during the intraoperative judgment, this additional extension bar can help to provide helpful information. Certainly, our group have published several years ago how to make intraoperative judgment using some simple principle like this. And in addition, I feel that if you can use Facebook, I think the midline, the occlusal plane can also, or even the chin position can be further assured before the fixation process. So this is the Facebook that I have used for many years, and this using the external ear canal to fix the modified Facebook and determine the midline before the surgery. And from the 3D simulation, we will know where is the next movement for the midline for soft tissue, midline for dental, the U1, L1, and also midline for the chin. And these all can be defined or can be used to make sure that the new position is what we want. And then we proceed to do the fixation. This is an example of a patient, skeletal mature patient with left side credit and palate. And you can see that not only the occlusion, not only the AP asymmetry, not only the AP discrepancy, but she also has the chin deviation. The cleft side, left side is smaller, vertically smaller than the non-cleft side, which is on the right side. So this is the 3D simulation before and after finishing the simulation. So from this simulation, we obtain some information like in here, the LIFO1 advancement in the left side and right side. And this information that I can use when I position the maxillomandibular complex, I will know how much to advance from each left or right side. And also how much I need to shorten, because this patient, for example, here I need to shorten the right side for 3 millimeter, shorten the left side for 4 millimeters. So with this information, I can go ahead to, after I cut the default one, and then I do the shortening. So here is the patient after this operation. You can see before and after a more harmonized facial profile has been achieved after the crepe orthodontic surgery. And this is the smile view. The occlusal plane has been corrected level after the orthodontic surgery. And you can see this warm eyes view that we actually did a yaw rotation. So you can see that the crepe side, left side is advanced more than the non-crepe side. So with this occlusal spring with the expansion bar, horizontal, vertical, can provide the information for the new position of the maxillomandibular complex. And here, when patient lay down, you can realize that how to position the maxillomandibular complex using the single spring method, and it provides the not only the midline but also the yaw rotation, pitch rotation as well. And also with this Facebook, I can make sure that this midline is achieved before the fixation. So let me show you this video, how I use this material. So this is the design, and later on I will also describe how I make the design of this extension bar. So after the fracture osteotomy for the maxillar mandible, so I wire the two jaws together within the occlusal spring. So then I could start to mobilize the maxillomandibular complex to the new position. When I position the two jaw, and also this image can provide, in for example, in this case, the right maxilla is mobilized less than the left maxilla, meaning that the left maxilla is moving more. It's a yaw rotation. So when I confirm this position, I can start to use the mini plate for immobilization. And certainly during the immobilization, I repeatedly check the position, the midline, the occlusal level, and also his rotation. So I would my assistant to hold the maxillomandibular complex in place. Then I perform the fixation process using the mini plate and screw. So I finish the right side medial pillar fixation, and I check with my Facebook again, and then I proceed to put the plate in the left side, and during the whole process, the Facebook, the extension bar is there for me to recheck anytime during the fixation. I just want to make sure that the new position is correct. Certainly after the fixation of the two medial pillar, I will recheck again. If not satisfied, I will release all the fixation and do the positioning and fixation process, repeated the process. If I'm happy with this position, then I remove the face ball and then do the remaining fixation in the lateral pillar. So in this case, I use the 3-hole mini plate to fix the lateral pillar. So finishing up all the before one fixation, the whole maxillomandibular complex should be in the right position, exactly what we planned during the 3D preoperative simulation. So then if I achieve the final good position, then I proceed to fix the BSSO, the mandible. Certainly, I trim the excess portion of the mandibular bone. Then I do transoral, transcutaneous bicortical screw fixation. I like to use 14 millimeter long screw, 3 screw to fix the BSSO on each side. And then after the fixation, again, recheck just to make sure that it's okay. Otherwise, you have to redo it. So finishing the fixation, I release the intermaxillary fixation, and I check with the occlusal spring in place if the occlusion is in the ideal position. And then I look at the whole face, both sides, if it is in the good position before we finish the operation and close the wound. And in this case, I think the result is pretty acceptable. This is the patient in the video. This is before the operation and after the operation, and you can see that before the operation, he has facial asymmetry. Also, the AP discrepancy from both sides of the cheek. And after the operation, his appearance has been much improved. And this is also another patient with facial symmetry. And we use the same design 3D simulation. And you can see one side shortened, the other side lengthened, and also different advancement from both sides that reveal the use of the yaw rotation. And you can see here the conventional occlusal spring and the new occlusal spring with extension bar. And I think it's easy to believe that the new occlusal spring really is quite helpful. It's quite informational that during the operation that you feel more confident to confirm the position of the maxillomandibular complex before you fix the default one area. And also here, you don't need to release elevate the lip to see the occlusal level. You can directly check with the patient's soft tissue in the rest position and check the level, the occlusal plane, and also the mid-sagittal plane. And this is the patient before and after the operation. Also before and after the operation. Now, I think the design of the occlusal spring is similar in the first, in the initial part, which is to use the software to design the occlusal spring. Once you position the upper and lower dentition in the ideal final occlusal relationship, and then you design the occlusal spring. You smooth the upper and lower part, the inner and outer part, and you can decide the thickness of the occlusal spring. For example, 2 millimeter in the upper part, 2 millimeter for your dental dental insertion and 2 millimeter in the lower part. And this is up to your practice, which thickness of the occlusal spring that you prefer. And then this extension bar is already predetermined, just an image, 3D image there. So you just attach to the occlusal spring image. Then altogether it become a composite image, and then you send to the 3D printer for to print out the occlusal spring with extension bar. So you can see intraoperative. The surgeon report that this is real helpful, and the surgeon also feel that this additional extension bar did not interfere with the surgery, and it really provides more information, not only by direct inspection, but also by using the Facebook, you can achieve a much better accuracy. And also, we have some objective evaluation here. You can see that we check the pitch royal and also the chin position, and also the midline deviation, and the result is quite successful and acceptable. So thank you for listening, and I believe that if you wish to have this new occlusal spring, really is not difficult. We published the paper, so you can check the paper and you can ask your engineer or software people to design this occlusal spring for you. Thank you.
For the cleft management in Chang'an, including nasal alveolar molding before the surgery, and lip repair at 3 months of age, and palatal repair at 1 year old, and we routinely do the secondary alveolar bone grafting. And finally, when the patient grown up, we will decide whether we need to do the OGS or not. So we mostly do 2-jaw surgery because we want to achieve a more harmonious facial profile, and it can also improve the post-surgical stability. It includes the level 1 osteotomy, maybe 1 pieces, 2 pieces, or 3 pieces, and BSSO. Some surgeon use the obigator, or some surgeon use the Hamsock. And we will do the genioplasty according to the patient's profile. Like this patient, as a cleft surgeon, we want to achieve a more harmonious face and beautiful face for the cleft patient. Like this patient, we do maxillar advancement and extrusion, mandible advancement, and genioplasty elongation to fit his body height. So, and lip nose revision. And finally, she become a beautiful girl. And this also a unilateral cleft lip and palate patients. We do maxillar advancement and BSSO setback, and finally lip and nose revision. And also this handsome boy, we do maxillar advancement, BSSO setback, and finally lip and nose revision. And this bilateral cleft lip patient, actually, she has bilateral alveolar cleft because failure of the alveolar cleft bone grafting. So we can, during the surgery, there are 3 pieces, and we cannot fracture the premaxilla. So after the surgery, she underwent orthodontic treatment to pull down the premaxilla teeth, and finally to achieve an acceptable facial profile. And this is also bilateral cleft lip and palate patient. We do maxillar advancement, BSSO setback, lip and nose revision for her. For my own experience from 2018 to 2020, there are totally 74 cleft OGS. Mostly they are unilateral cleft lip and palate. And that include 4 redo cases because of the maxillary collapse, 2 occlusal cant, and 1 mid-face retrusion. And there's include 1 bilateral residual alveolar cleft, like I have talking about before, and also include 3 unilateral alveolar cleft, include 2 redo cases. So the spatial issues I want to talk about today is how about the alveolar cleft? How shall we do with the alveolar cleft? And the second issues is how about the maxillar stability in the cleft OGS? And shall we put the bone graft? And the third is how about the pharyngeal flap and OGS? And finally is the VPI. So you could do alveolar bone grafting or GPP combined with the OGS, and the GPP is possible when the 2 segments are approximated during the surgery, like Dr. Wang said. Like this case, the segments are not approximate, so finally there are failure of the bone formation. Like this case, there are segment approximation, so finally you could see there's bone connection between the alveolar cleft. If you want to do the alveolar bone grafting combined with the OGS and there's no segment approximation, I suggest you could use the gingiva flap elevation like a secondary bone grafting methods. So it is a short video demonstrate how we did the surgery. This is a case who is a 51-year-old woman who had OGS before, but had a maxillary relapse. And she also had a alveolar cleft because there's a previous failure of the bone grafting. So we do the incision like a secondary bone grafting. So this time she want to do the OGS because she want to do the denture on the front teeth. And there's a very bad occlusion and there's no bone formation during the alveolar gap. So you could do the dissection like secondary alveolar bone grafting. So if you want to put the bone graft, you have to repair the nasal floor very secure to make sure there is no leakage from the nose. So after the down fracture, you do adequate mobilization and put on the dental the splint. Use the mini plates and screws to do the fixation, and finally check the occlusion. We harvest the iliac bone marrow graft to put on the alveolar cleft. So usually I will put very firmly of the bone graft. And I will harvest the inner table of the iliac bone. There's the cortical bone to cut into like a triangular shape and put on the layer of the nasal floor. These methods, you could prevent the nasal leakage from the nasal floor, and it will prevent the further infection of the alveolar bone graft. So you can also put another bone graft on the other side of the maxilla. So finally, close the wound like a secondary bone grafting. And finally, we put a dental splint to prevent the collapse of the maxilla because the patient has 2 segments. And usually the dental splint, the palatal splint will stay on the mouth about like 1 month. And we use the wire to do the fixation. So this is the case we demonstrated before. So you could see that on the combi CT, there's no bone formation. Before and after the bone grafting, you could see the bone formation. So the second I want to discuss is the maxilla stability and the cleft OGS. The cleft OGS, they are more prone to surgical relapse because there's a scarring alveolar tissue, and sometimes there's a failure of the bone grafting, so there will be 2 segment or 3 segment, so lack of strong and symmetrical skeletal foundation, and sometimes there will be pharyngeal flap, and the patients always have a poor dentition. Like this review and meta-analysis article this year, it shows that the mean maxilla advancement relapse was about 17%, and the mean downward movement relapse was about 40%. The mean clockwise movement relapse was 33%. However, it is controversy in the literature in relation to intraoperative surgical movement and higher relapse rate. The suggestion in this article is that the alveolar bone graft is necessary. One-piece maxilla surgery is advisable for transverse stability. And you may put the bone graft during the OGS. However, some surgeons, they will suggest that it will increase the infection rate. The meta-regression results suggest that there's no reason for overcorrection, and 4 mini plates placed vertically and 1 mini plate placed horizontally to bridge the grafted area. After the operation, the maxillomandibular rigid fixation is not advisable because it probably will make the relapse more worse. So you should use the light gliding elastics. And palatal pedicle preservation in cleft linen palate patient is considered essential. So the other article in 2012, they also talking about the relapse rate in the horizontal is about 20% to 30%, and the vertical relapse is about 50%. So the horizontal relapse is like a moderate relapse rate, and the vertical relapse is high relapse rate. How about the advancement amount and the relapse? So this article published this year, they separate the patient into 3 groups, like minor group, moderate group, and major group. And interestingly, they found in the minor group, the relapse rate is higher, is about like 32%. And for the vertical relapse rate, for the minor and the major group, is about 33% and 45%. However, there's no significant between the type of cleft, pharyngeal flat, bone graft, or the numbers of the mini plates. So the suggestion in the article says that you should do the complete mobilization of the level 1 segments and do a very good orthodontic treatment after the surgery. And he suggests that overcorrection of 10 to 20% in a horizontal direction when treated with the cleft lid and palate patients. Actually, Hugo Begay also already talking about down fracture and adequate mobilization of the maxilla was the key in maxillary advancement. For my point of view, I think the pterygomaxillary disjunction is the most difficult part in the cleft OGS. So usually we will do use a right angle saw to weaken the pterygomaxillary junction, and use the Kawamoto or Daughtry Monroe to disjunction the pterygomaxillary area. I found sometimes you probably think that you already fracture the maxilla and it's already have a mobilization. However, sometimes there's still some bone, like pterygoid bone, will connect it to the posterior wall of the maxilla, and there will be the muscle pull on the maxilla. So it probably will get relapse on the maxilla. So how about the bone graft? There's articles suggest that if you advance beyond 8 to 10 millimeters, you should put the bone graft. In the patient, the cleft OGS patient with a bone graft, the horizontal relapse rate is between 23% to 36%. Some authors suggest that the bone grafting is required only when the amount of advancement is over 6 millimeter. There's a paper published in 2018. This article excludes all the cleft cases, and they found that the bone graft has preventive effect on horizontal maxillary stability with an average of 1.72 millimeter less relapse. So in our center, Professor Yufang Liao, she performed a retrospective study including 60 cleft patients with single orthodontics, and she performed used the 3D Combi CT for bone stability measurement, and she separated the patient into Team A, who put the maxilla bone graft, and Team B, who didn't put the bone graft, and she found that the only factor for maxilla stability is the amount of surgical change. She found that the larger amount of maxillary advancement was related to higher sagittal relapse and relapse of pitch rotation. This study also shows that long-term stability in both groups. The mean advancement is 5.7 millimeter in UCLP and 3.6 millimeter in BCLP. The relapse rate is only 10%, which is less than the articles before. So you could see in the table, the only thing that has statistically significant is the change of the surgical movement. So how about the pharyngeal flap? There's one study, they compared patients with or without pharyngeal flap. There are totally include 19 patients. And in the group of the patient with pharyngeal flap, 2 takedown during the surgery because of a significant advancement. And they found there's no difference in relapse rate between the 2 groups, likely as a result of the use of rigid internal fixation. And the patient who had takedown of the pharyngeal flap would result in increased hypernasality. So there's another paper who also performed the surgery, talking about the patient with the pharyngeal flap. Very interestingly, they found that there are 5 patients has pharyngeal flap. They improved the speech after the surgery. So they suggest that the presence of a pharyngeal flap prior to maxillary advancement may prevent the development of VPI and may even improve the BP function. However, in this study, they are not mentioned about relapse rate. So recently, we did a retrospectively review from 2016 to 2020. We include a cleft patient with pharyngeal flap underwent the 2-jaw OGS, and whether to divide the pharyngeal flap depends on the ease of the maxillar advancement. So there are include 26 patients, and we want to know about the relapse rate and how about the speech. So about the speech, there are totally 20 patients has postoperative speech assessment. And in the pharyngeal flap remain group, there's no need for VPI surgery, but after surgery, 2 complaints about OSA. In another group with a pharyngeal flap division, 2 need redo the pharyngeal flap and 4 need furlough, palatoplasty. So there are totally 60 patients need VPI surgery. So the other thing we want to know about the pharyngeal flap is the relapse. So there are, so far, we totally measure about 21 patients, and we found the pharyngeal flap remain group, the A-point advancement is about 3.84 millimeter, and the other group, pharyngeal flap division group, is about 6.1 millimeter. The relapse rate in the pharyngeal flap remain group is about 44%, and the pharyngeal flap division group is about 27%. So from the preliminary study, we can find that if you do the pharyngeal flap division during the OGS, you probably will have a better stability However, you probably have to inform the patient. She probably need to do pharyngeal flap or furlough palatoplasty after the surgery. So finally is the VPI and the cleft OGS. So from the literature review, they always suggest that if you advance the maxilla larger than 7 to 10 millimeter, you will have a greater risk of VPI. And if you have an inadequate or borderline VP function before the surgery, you probably will have a higher risk of postoperative VPI. From lateral step, you could also see that the palatal length and the pharyngeal depth to predicting the VPI rate and the need for a pharyngeal flap. So this year we published a paper. We studied 25 UCLP and BCLP patients. They have a complete speech assessment, MPS and VFS study. All had an adequate VP function before the surgery. The mean maxillary advancement is 5.7 millimeter. And of the 25 patients, the 8 patient has a VP function change into marginal or insufficient. 3 out of 25 patients had furlough palatoplasty for the VPI. From the video fluoroscope, we found that if you could do the clockwise rotation of the MMC, can be considered an alternative instead of translational maxillary advancement to prevent VPI in such patients. So the conclusion of my speech is that the cleft OGS is more prone to relapse on the horizontal direction and more on the vertical direction, and overcorrection might be needed. And complete disjunction of the pterygomaxillary junction is the key. Bone graft is needed in larger advancement, maybe larger than 6 millimeters, you should put the bone graft. And pharyngeal flap can be divided when maxillary advancement is limited, but further VPI surgery might be needed. Thank you for your attention.
The following section is about patient satisfaction and quality of life after orthodontic treatment for cleft lip and palate deformity. I am Yishan Chen. In our Chang'an Memorial Hospital, patients with cleft lip and palate receiving the following protocol with orthodontic treatment. In stage 1, age around 0 to 3 months, we will perform nasal alveolar molding NAM, which prepares for primary repair of nose and lip. And in stage 2, during the age of 8 to 12 years old, we will perform only maxillary fixed orthodontic treatment to prepare the area for secondary alveolar bone treatment for severe incisal malpositions, for example, tilted or high or retroclined or rotated upper incisors, severe lateral segment constrictions, wide alveolar cleft, or severe displacement or mobility of the premaxilla in bilateral cleft lip and palate. And during stage 3, around age 13 to 7 years old, after the peak of growth spurt, we will perform a full mouth orthodontic treatment alone to correct space problems, midline discrepancy, dental anomalies, or mild to moderate jaw discrepancies. If the patient suffered from severe jaw discrepancy, then we will perform stage 4. The patient is older than 17 years old. After late teens, And we will perform full mouth fixed orthodontic treatment to correct moderate to severe jaw discrepancy or wide alveolar cleft due to previous ungrafted alveolar clefts or failed alveolar repair. And patients with cleft lip and palates will require very long multidiscipline cleft treatment. From stage 1 to stage 3 or 4, it will take around 15 to 20 years. And at the end, we will include orthodontic treatment with or without orthognathic surgery to align the teeth and jaws. In this stage of patients, patient with often presented with residual dental or facial deformities, including class 3 facial profile, concave lateral profile, maxillary retrusion. And in UCLP, we often see that there's tilted upper incisors. And in bilateral cleft lip and palate patients, we often see severe retroclined upper incisors. And in the literature, it reported that 70% of the cleft lip and palate patient will reveal missing teeth. Therefore, patients during the stage in adolescent or adult patients often experience some degree of social discrimination and stigmatization among peers. And it will affect their quality of life, QOL, including facial appearance, mastication, and body images. So the important outcome for parameter in this successful rehabilitation is not just the objective clinical parameters, but also patients and their parents' satisfaction is the most important outcome parameters. However, if we review the literatures, we will find that few studies have evaluated the outcome of satisfaction with appearance and perception of patient appearance as a measure of QOL for patients who had multi-stages procedures for cleft that included surgical and orthodontic treatment. Therefore, we have conducted a prospective cross-sectional study, and the result was published this year in Clinical Oral Investigation this year, and we would like to share this, the study with you. The aim of this study was to survey patients who had complete orthodontic treatment for cleft lip and palate, including to measure patients' satisfaction with facial appearance, to measure perception of facial appearance as a measure of QOL, and to identify factors that might influence these outcomes. Material and methods. The inclusion criteria will include a NAM before 3 months of age for cleft of nose, lip, alveolus, or palate using modified Grayson or Figura technique. Second, will receive nose and lip repair at the age of 3 months of cleft of nose and lip using modified rotation advancement. Including receiving palate repair at the age of 1 year old for cleft of palate using 1 stage 2 flap palatoplasty. And in the stage 2, they will also receive secondary alveolar bone grafting from iliac crest at the age of 9 to 12 years old for alveolar cleft. Then the patients will receive a complete full mouth orthodontic, pure orthodontic treatment or combined with orthognathic surgery during the past 3 years in Chang'an Craniofacial Center and treated by a single orthodontist, Professor Yufang Liao. And the patients then will receive with or without lip nose revision. And these patients are absent of genetic syndromes or other congenital malformations. Agreed to complete questionnaires after orthodontic debondings. The study design are composed we're measuring tooth numbers of each patient, and the patients are required to fill in 4 kinds of self-assessment questionnaires to to measure the satisfaction with facial appearance. First is the OAR scale, overall appearance rating. Patients were asked to evaluate how would they evaluate their current face and ideal face. And the scale is from 0 to 100. 0 is extremely attractive. 50 is ordinary, and 100 is extremely attractive. Higher scores indicate greater satisfaction. Second is a SFA scale. This is a scale that evaluates the satisfaction with specific region of facial appearance. Patients were asked how would they rate their satisfaction over their nose, cheeks, lips, teeth, upper gum, chin, and facial contour. And we're using a 5-point Likert scale from 1 to 5. 1 is very dissatisfied and 5 is very satisfied. Then the patient are required to evaluate their perception of their facial appearance. We're using a Chinese BIQLI scale, and it will present the body images. And the patients were asked to evaluate how do they evaluate their own chewing, speech, smile, self-confidence, and social life. This questionnaire is used as a 10-point Likert scale from 1 to 10. 1 is very dissatisfied and 10 is very satisfied. And the last patient were asked to report their satisfaction related to expectation. They were asked to check the best describe their treatment result relative to their expectation, including much lower, lower, the same, higher, and much higher. This is the form they are going to fill in. And the statistic analysis, including pair t-test, to compare overall appearance rating score between the ideal face and the current face. Second, the one-way ANOVA to test the difference in the mean score for specific facial areas among different types of cleft. Chi-square test, to test the distribution of the outcome relative to expectation among different types of cleft. And finally, we are using multi-logic regression to see the relationships between satisfaction of QOL and the independent variables like age, gender, cleft type, treatments, tooth numbers, predictors, and predictors of participants' result being lower or much lower than expected. This is our result, and we'll present it in 7 tables. In table 1, we recruited a total 213 patients. The mean age is 22.8 years old, slightly more male patients, and slightly more than half receive orthodontic combined with OGS, and slightly more 1/3 of patients receive lip nose revision. And the cleft type, most patients, 47% of patients are UCLP, and 24% of patients are BCLP, 18% of patients are cleft lip or alveolus, and only 11% are cleft palate patients. And the tooth numbers, we found that 31 patients has no missing tooth, 74 patients has only 1 missing tooth, 58 patients has 2 missing teeth, 38 patients has more than 3 missing teeth. And we found out during the treatment with or without orthodontic surgeries, patients have similar tooth numbers. And in the total treatment patients, 56% of patients experience extraction orthodontic treatment to resolve midline discrepancy, dental crowding, tooth decay, or camouflage treatment. And table 2 shows the satisfaction rating scores following treatment of OAR and SFA. In the SFA, in the OAR group, the ideal face and we compare the ideal phase and the current phase. And most of the patients shows moderate level of satisfaction in the current phase. And they show more satisfaction over ideal phase than their current phase. And in the SFA score, nose showed the lowest score, and teeth and upper gums showed the highest score. BCLP group showed less satisfaction with cheek than UCLP group, while in the lips group, BCLP group showed the least satisfaction than cleft palate and cleft lip and alveolus group. Isolated cleft palate shows the most satisfaction. Table 3 shows the results of BLI-QI. And all in the BIOLI scale all showed a moderate level of satisfaction, and highest satisfaction in cleft palate group, and non-significance in different types of cleft palate patients. Table 4 shows a relationship between SFA and OAR with different factors, including age, gender, cleft type, and different treatment tooth numbers. In the factor of age, gender, tooth number show non-significance with SFA and OAR. In the cleft type, UCLP, BCLP, and cleft lip and alveolus shows negatively related to satisfactions with lips. When type of treatment was examined, only OGS combination was positive related to participants' OAR. OGS combination was also positively related to SFA for all areas. Lip nose revision was only positively related to satisfaction with the nose. Table 5. Relationships between aspects of QAO following treatment and demographics, cleft type, treatment, and tooth number for participants. The only relationship between demographic variables was between gender and smile. UCLP and PCLP patients were negatively related to smile. Other negative relationships were found between BCLP and chewing and social life. Table 6 shows satisfaction with outcome relative to expectations. And we found that around 50% of total 213 patients showed higher and much higher satisfaction outcome to their expectations. And in UCLP patients, more than 50%, 55.5% patients showed higher and much higher satisfactory outcome to their expectations. And in Table 7, relationships between participants perceiving their treatments result as lower or much lower than expected, and to their demographic, cleft type, treatment, and tooth numbers for participants. Lower or much lower expectation were all showed non-significance to all factors. Discussion. This cross-sectional study provides comprehensive information on patient satisfaction with facial appearance and the impact of facial image on QOL after complete full mouth orthodontics for the 4 following cleft types: UCLP, BCLP, cleft lip and alveolus, and isolate cleft palates. And we'll see through some individual factors. First is the cleft type. In our study, BCLP is negatively related to overall satisfaction. And it is similar to the previous study. Van Leerder showed that UCLP were satisfied with their facial profile after treatment, and Kriegran showed low satisfaction in adolescents with UCLP, BCLP, facial clefts, and hemifacial microsomia patients. And if we're focusing on the specific area, in our study, 38% of UCLP and 52% of BCLP needs lip nose revision. So it means that after all this orthodontic treatment, lip and nose revision is crucial. And the patients also show highest over dental and gingival appearance. That means they are satisfied with their well-aligned upper and lower anterior teeth and their upper incisor exposures. And in the previous studies, they also showed that lower scores on lip and nose, and less satisfied over upper lip and nose than jaw and face. And the body image and QOL all showed moderate level. It is true that the BCLP all show lowest in the chewish function, and they may need further improvement over treatment. It is similar to the previous study that normal adolescent satisfaction with body image and QOL. Gender. In our study, that the only significance is smile satisfaction, where that females are more satisfied than male. And this is controversial in the literature and may need a further investigation. Age. In our study, it shows non-significance. And in 2011 CLAP-Q study showed that older age associated with poor results. And younger participants has higher scores for most scales, including appearance, oral health-related QOL, psychological, and social scores. And considering the missing teeth over the tooth number, the old impression is that missing teeth may cause speech and mastication dysfunction. However, in our study, we showed that non-significant difference with satisfaction with overall facial appearance, QOL, and treatment result. And in a 2008 systematic review also showed that insufficient evidence is to conclude dental agenesis affected oral health-related QOL of children, adolescents, and young adults. In our center, we focus more on patient-centered approach and with more two-jaw surgery rather than simple maxillary advancement. Orthodontics should consider deferring complex camouflage orthodontic treatment until facial growth is complete. Orthodontics should provide the option of skeletal facial reconstruction to patients with moderate jaw discrepancy to maximize treatment stability and satisfactory appearance outcomes. The limitations of this study is remember what the participants' expectations were at 4 months orthodontic treatment was completed, may be impaired and biased. And in this study, the age range was very large, so long-term follow-up until adulthood is needed. And we may need feedback from the clinicians to complete the whole evaluation. So the conclusion of this section is orthodontic treatment has a positive effect on facial appearance and QOL on patients with cleft lip and palate. Type of cleft, OGS combination treatment, and lip and nose revision significantly influence satisfaction with facial appearance. Efforts must be taken to modify treatment strategies for patients with BCLP in order to improve satisfaction with appearance and mastications following the treatment. Thank you.